Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Hello, and welcome to the Medscape Live webinar, a how-to guide to the use of anti-amyloid therapies. Today we'll be talking about recommendations for setting up your practice in the real world. My name is Dr. Michael Rosenblum. I'm an associate professor of neurology at the University of Washington Memory and Brain Wellness Center in Seattle. And I'd also like to introduce my esteemed colleague, Dr. Malaz Bustani, who's the Director of Care Innovation at Eskenazi Health at Indiana University School of Medicine. Today's presentation is divided into 5 different parts. First, we'll provide an introduction to the use of anti-amyloid therapies in clinical practice. We'll move on to discussing a framework for starting anti-amyloid therapies in a healthcare system. We'll then move on to talking about the interdisciplinary team that is necessary for not only planning such a program, but also maintaining a program throughout. We'll move on to the potential barriers to using anti-amyloid therapies. And here we'll talk about barriers in healthcare systems, but also barriers faced by private and rural practices. So let's start with an introduction to the anti-amyloid therapies. I'll now pass things over to Dr. Bustani.
Thank you so much, Dr. Rosenblum. I'm just going to give you a quick introduction about the efficacy and the safety profile for 2 medications that are considered anti-amyloid therapy that have been approved by the FDA in the United States over the past couple of years. The first one is lecanemab, and it specifically binds to the A-beta protofibrils and plaques. And then the second one, which was approved almost a year ago, donanemab, target a form of A-beta that present only in amyloid plaque. Both of them are considered disease modifying through reduction in amyloids. They are indicated for specific biomarker confirmed presence of amyloid and therefore Alzheimer's disease, but they need to be in the early stages of cognitive impairment, defined by having mild cognitive impairment due to Alzheimer's disease or mild dementia syndrome due to Alzheimer's disease. Both are administered by IV infusion. In regard to the efficacy for lecanemab, both of them, the efficacy was done at 18 months, and they were measured by what we call CDR, or Clinical Dementia Rating Sum of Box. It captures cognitive symptoms and functional symptoms, and it also have been evaluated by more specific cognitive measurement called ADIS COG 14. And you can see over here that after 18 months, there was statistically significant reductions of around almost a half a point on this CDR sum of box, which is up to 18 points, and almost 1.5 point on the ADS COG that measure cognition. Regarding the donanemab, very similar, although they used slightly different tools. So I'll focus first on the CDR sum of box, which is very similar to lecanemab. And you can see after 18 months, again, statistically significant, almost a half a point or more compared to the placebo. And then from regard to the Alzheimer's disease cognitive score, they used something called integrated Alzheimer's disease rating scale that focus on the cognition, and similar around 3-point differences compared to the placebo. Then in the donanemab, they also measured the percentage of amyloid clearance as measured on PET within 24 weeks and 18 months. So you can look at 18 months, there was 76% reduction in amyloid load as measured by the amyloid PET scan. And then they also measured time to worsening in the clinical dementia rating global scale. And this CDR can tell you if you are normal cognition or mild cognitive impairment or mild dementia stage, moderate dementia stage, and severe dementia stage. And they try to figure out how much delay in moving from one stage to another. So moving from mild cognitive impairment to mild dementia, or from mild dementia to moderate or severe dementia. And the hazard ratio was approximately 0.63, or almost 37% reduction in that time, or approximately 6 months in an 18 months window. That's the benefit. Let me focus now on potential adverse effect. One of them is the infusion reaction. In lecanemab, almost 1 out of 4 people have some kind of infusion reaction. Seriously was almost 1%. In the donanemab, the infusion reaction dropped to almost 9%. Most of them happen after the first dose, and they never come back, and you can manage them by stopping the infusion or reducing the rate, or maybe consider for the next time pre-treatment for these reactions with, for example, prednisone or antihistamine. Most of them were mild reaction from the infusion. Regarding more specific safety concern related to these anti-amyloid therapy, there's a term called ARIA, or amyloid-related imaging abnormality, and they are primarily microbleeds that you pick up on in the brain MRI, or swelling or edema. Most of these ARIA happen early in the treatment, the first 3 to 6 months. They are usually transit, and you can manage them. Most of the cases are asymptomatic, are usually detected by active surveillance with the brain MRI. And when they became symptomatic, these symptoms include headaches, unsteadiness, confusion, some visual disturbances, and dizziness. The rate of any kind of ARIA, if it's microhemorrhage or edema or swelling, around 22% in lecanemab compared to 10% of the placebo, and around 37% in donanemab compared to 15% of the placebo. And in the donanemab, recent studies showed that you can reduce that risk if you titrate donanemab a little bit slower than originally. The serious ARIA are very rare, and lecanemab less than 1%, and donanemab almost close to 1.5%. And now I'm going to hand it back over to Dr. Rosenblum to tell you about using anti-amyloid therapy and the framework for integrating it.
Thanks, Dr. Bustani. So let's discuss the Alzheimer's management continuum. And this is a process that begins in the primary care clinician's office. So when a patient has complaints of memory loss, they are most likely to encounter their primary care clinician. They also may encounter the primary care doctor through routine care and prevention visits. And if a patient has memory problems, it is expected that some type of cognitive assessment be performed. This could be the module cognitive assessment. This could be the mini mental status exam. And then should that testing be abnormal, then the primary care provider may decide to proceed with laboratory studies like B12 and thyroid, and neuroimaging such as MRI to rule out CNS lesions. Now, during this workup process, a patient who may have early stage dementia or mild cognitive impairment may be identified. And I think at that point, this patient can be referred to the memory specialist. And it is within the realm of the memory specialist to confirm whether or not Alzheimer's is present biologically with either CSF biomarkers or amyloid PET biomarkers if the patient is suspected of possibly having an Alzheimer's process. At that point, if a patient is confirmed to have Alzheimer's within the brain, a conversation about whether or not they are the best fit for an anti-amyloid treatment can be had, and then the memory specialist will be the one who would start the medication, be it lecanemab or donanemab, and then proceed with the ongoing surveillance with serial MRI imaging. So you can see on this continuum, you have the primary care clinician in the diagnosis and preparation phases, and then the specialist is involved with treatment and monitoring response to these drugs. So let's say you're trying to decide whether or not to adopt anti-amyloid therapies into your clinical practice. There's various stages, and I can tell you from experience that there's a lot of work up front, but afterwards it gets easier. So first and foremost, one must appoint a physician champion who will lead the implementation and may be accompanied by a care coordinator who could also help with this process. Development of pathways, particularly pathways for what to do to work up memory loss or cognitive impairment. How do you decide what patients are appropriate to treat? There are very good guidelines that have been developed, the appropriate use paper that was published recently. In addition, developing protocols for intervention should a patient develop amyloid-related imaging abnormalities is also of chief importance. And don't forget to also think about protocols for financial assistance. These medications can be quite expensive. Next, adding the drug to formulary, which could include lecanemab or donanemab or both, and then determining what biomarker is best for your system. You may not have access to amyloid PET, and therefore you may consider a fluid biomarker. You also want to make sure you have sufficient capacity within your infusion center and imaging center to handle the patients that you decide to treat. And then creating a variety of workflows that ensure safety. At our site, we developed a protocol specifically for patients receiving monoclonal antibodies. And then finally, making sure everyone's on the same page, providing education, not just to your fellow specialists, but also primary care providers, the infusion center, and your clinic support staff is of great importance. Now, I talked about pathways, and here's an example of what we have been doing at University of Washington, and in my conversations with Dr. Bustani, very similar to what is done in Indiana. So during the first visit, a patient may present with symptoms of memory impairment. A cognitive screening may be necessary. Laboratory studies and neuroimaging may also be ordered during this visit. And the extra step of checking a biomarker should there be suspicion for early stage Alzheimer's disease. Once these studies are ordered and the results come back, we have the patient return for a family meeting several weeks later where we discuss the diagnosis and prognosis of early stage Alzheimer's disease. And then we go through the process of determining the risk benefit of starting an anti-amyloid therapy. If we feel that the patient may be a good fit and the patient is interested, we'll also start the financial assistance documentation, which can often be a rate limiting step. So you want to start that early on in the process. We then move on to ordering studies for risk stratifications. We know that the risk of ARIA goes up with the number of copies of ApoE4. So we order ApoE genetic testing and coagulation factors, and then have the patient return for a third visit. We then talk about the risk for ARIA versus the benefit. The patient then provides consent. We enter them into the registry, and then our clinicians will place the order for the infusion of choice, followed by the surveillance imaging study orders. Now, at University of Washington, we developed a monoclonal antibody approval board. This is for adjudication for those complex cases that may not fit within the usual treatment guidelines. So, for example, a patient who has primary progressive aphasia due to Alzheimer's disease may score below the cutoff on the MoCA or mini mental status exam and have perfectly intact function. It is these patients that we discuss at these approval boards, and it consists of several neurologists, such as myself, also a neuropsychologist, and neuroimaging. We have these discussions to make sure that we're doing the best thing for our patients. Dr. Bustani, do you want to say a couple of words about how things are done at Indiana University?
So Indiana University has 3 separate healthcare systems where most of the faculty practice. So we have what we call Indiana University Health, and then we have Ashkenazi and VA. We practice in Ashkenazi, and in that circumstances, we have empowered our memory care practice to discuss the benefit and harm of these treatments, manage the complex cases, and we felt that having approval boards might actually slow down our process and it might delay the opportunity. The population we serve are very vulnerable. They have social economic vulnerability, and sometimes it takes us a while to get them on board to just work up and see if they're meeting the criteria. And we get very nervous by delaying that time because the window is relatively short. So for us, we empowered our memory care practitioners. We created protocols and guidance for them, and they make that decision. But again, each system has a different context, different need, different localization. And we just want to share with you at least two.
Thank you, Dr. Stein. That makes perfect sense.
So a little bit more on managing ARIA, and more specifically in ARIA, you have to detect it first, and then you have to know what you have to do after detecting it. And the best way for detection is this active surveillance through the MRI. The surveillance for ARIA, but lecanemab and donanemab, there's not much differences. So for example, you really need to look for recent MRI as baseline in the past 12 months. And then for lecanemab, you do one before the 5th infusion, before the 7th infusion, and then before the 14th infusion. For donanemab, you do one before the 2nd infusion, one before the 3rd, one before the 4th, and one before the 7th. Or the infusion in the donanemab is once a month, lecanemab is once every 2 weeks. So their variation you see are related to the frequency of the infusion itself. And then if you look at how you can manage ARIA, it's obviously the first thing with the clinic visit, you review the infusion side effects and the outcome, and you want to review the MRI with your partner radiologist. And imagine the ARIA was identified on the MRI. So the first step is categorize it into hemorrhage or a bleed or microbleed usually, or edema or swelling. And then based on that, you come up with a treatment plan. So the treatment plan relatively straightforward. So based on the radiological evidence, if the patient has asymptomatic, so completely picked up by the surveillance, but from a MRI reading, they have mild ARIA swelling, or if they have asymptomatic ARIA hemorrhage, you can continue the treatment. But if they have symptomatic ARIA, doesn't matter if they are edema or hemorrhage, and if they have an asymptomatic one, but they have moderate or severe radiographic imaging, then you really suspend the treatment for that. And most of the time you discontinue that treatment. So that's kind of the summary of how you manage the ARIA if your surveillance picked it up. So I'll hand it over back to Dr. Rosenblum.
Thanks very much. So let's talk about the planning team that is necessary if you are interested in implementing an anti-amyloid therapy program. So it begins with the primary care clinician. He needs to know the appropriate patients to refer and what workup is necessary before that referral. Secondly, the treating physicians are involved with creating the inclusion and exclusion criteria for receiving these drugs and selecting the biomarkers that would make most sense for the system and developing processes for dealing with ARIA. Next is the infusion center, where there needs to be some type of assessment about capacity at the start, as well as protocols for what to do should patients develop infusion-related reactions. Then the MRI team, there needs to be a discussion about how do the reports report the findings of ARIA. Some systems have developed templates to make sure that their radiologists are clued into the presence of ARIA-H or ARIA-E. And then how does that information get communicated urgently to the prescribing clinician? At University of Washington, we have leveraged electronic medical record and used it in very novel ways to simplify the complex workflow that's associated with prescribing these drugs and ensure safety at the same time. You may not think about this immediately, but medical administration has been very important, at least to us. We've had a project manager who helped us with starting this process. We've also had help with determining the infrastructure necessary for this type of program, and then also how do we sustain this program. Clinic support staff includes care coordinator, the clinical assistants, and also the frontline staff And we'll say a little bit more in a later slide about care coordinators, which are really important. They serve as the glue to all these key stakeholders. And finally, pharmacy is necessary to engage to add the drug to the formulary. Here's the actually implementation and the care team for sustaining the program. And this includes the patient and caregiver, because these are the individuals who need to follow through with the visits and also undergo the surveillance imaging. They may reach out to the dementia specialist or to the primary care clinician if there are any problems. Also, nursing can serve as the initial go-between for the family and the clinic staff. The infusion team administers the treatment ongoing, and the radiologist will provide the feedback about whether or not the MRIs show abnormal changes or are completely normal, and the patient can proceed with the treatment. I want to take a step back and discuss a little bit more about navigators and coordinators. So at University of Washington, we have a coordinator who is extremely crucial. She is the communication factor that really is the first person to interact with families. She's also helping to facilitate urgent appointments, coordinating any issues with infusion and radiology, and making sure patients are entered into the registry. If I miss a step when I am treating a patient, she'll send me an inbox message and say, Dr. Rosenblum, you need to follow up on this. So this is how things are done at University of Washington. Dr. Bustani, you want to say a couple of words about Eskenazi Health?
Yeah, we have in Indiana University, we have very similar job description. We call it Brain Care Navigator, and we have extended that Brain Care Navigator functionality to include the early detection processes to pick up the patient who might be eligible for stuff. So they act as a glue between the memory care, primary care, and infusion clinic, on top of them navigating the patient and family during the entire treatment journey, including managing their financial needs and all the paperwork, and act like what Dr. Rosenblum said, as a backup or redundancy if any of our memory care practitioner missed a step in the process.
I just want to leave you with some tips. Number one, you heard about how approval boards may be appropriate or not appropriate depending on your healthcare system. We really found the EMR-based tool to be extremely useful. And then what we did when we started our program, we had weekly meetings with all key stakeholders until we had our first 5 patients undergoing treatment. This way you can even out any of the key kinks that are present in the system. The coordinator, as you heard, is extremely helpful. And then we recommend having connections with the infusion team periodically to ensure that you're not overwhelming them with patients, because we found that was a surprise issue at University of Washington. So let's go into some of the potential barriers to using anti-amyloid therapies. And Dr. Bustani, I'll have you kick off this discussion.
Absolutely. So I think for us, the biggest issue is early detection in the shortest period of time, so you can have eligible people to receive the treatment. And that was a major process. A lot of it is not just related to cost, but the workflow issue. The other thing is, unfortunately, if you go through the funnel, there was very small number of patients who make it to the infusion. They fall up on the funnel because of staging of the disease, the biomarker, the benefit and harm, and their eligibility, and obviously their insurance status. There's the private and rural practice. They are not usually have the resources that we have at Indiana University, where we can operate as an integrated system, and therefore we can bring over resources like the Brain Care Navigator. If you are in a private or rural practice, that type of upfront investment are going to be a major challenge. But in general, the last barrier we have found from our research is outside the academic center and safety net setting. It's really there's a slow adoption of new therapy. There's more risk concept. There's a lot of stigma. And these were major barrier that we have found so far.
Also going to chime in about tips or advice for smaller practices. I would say that there are various medical deserts around the Northwest, and sometimes there may not be access to amyloid PET or even CSF. In those cases, thinking about blood biomarkers is certainly worth a consideration. If you can outsource some of the imaging to other facilities, that certainly is also something that is worth considering. You have a smaller group of individuals, so that's a challenge when you're in a smaller practice. Figuring out how you are going to outsource some of the biomarkers if you don't have ready access to them. I think that's an important step. Dr. Bristone, anything else, given your experience for smaller practices?
One I noticed is bunch of small practice create almost coalition surrounded by other places in their regional network and create a bridge to a regional memory care practice. So a lot of innovation required in that place to overcome the barrier of access for very vulnerable population live in a rural area in particular or small practices.
In our system, we do use amyloid PET in about a third of our patients. And one of the problems we found is that in our system, actually, the reimbursement is not enough to prevent the system from losing money. And as a result, we have limited the amyloid PET use in our program. I think in the ideal world, it'd be nice to have a baseline amyloid PET and then one after 18 months where you compare changes in centiloid levels. But from a stewardship and cost effectiveness standpoint, our system probably would not be able to handle the costs associated with that. So let's move to some take-home points. All of you probably are familiar with the 2 approved anti-amyloid therapies. You've probably gathered multidisciplinary collaboration is critical. And then before you embark on this journey, you want to make sure you have established pathways for diagnosis, eligibility, and then safety. The coordinator is a really important part, and you need to figure out how do you get this person in your system working for this purpose. And you heard already about the barriers that may vary depending on whether you're a big system or non-academic or safety net practice. I want to thank all of you who have joined us today. Hopefully you have some helpful information that you can take back to your individual practices. Have a great day.